And then prior to that, Army. So I was in the Army. I've been in the Army about 13 years now. So combat medic, all that kind of stuff. So been doing this a little bit. The Impella device we're going to talk about today is a forward flow microaxial pump. Okay. So this is placed percutaneously. Okay, the ones that you guys are going to be placing or transporting is placed percutaneously, either through the groins or through the axillary artery. Okay, there's two different ways that we can actually do this device. Okay, just to go over a little bit about the device, the main ones you guys will see will be either a 2.5 or a CP. Okay, those are our two lowest flow devices. 2.5 equals 2.5 liters of flow. CP, 4.3 liters of flow for this device. Okay. So as you look at this actual pump, we have a pigtail, which is atraumatic. Okay, it just sits mid-ventricular space in the actual LV, and it's designed to just bump off any kind of structures inside the heart. Okay. Next, you have your inflow. Okay, so your inflow is sitting mid-ventricular space, all the way up to our outflow, which is sitting in the coronary takeoff or the aortic root at the coronary takeoff. Behind there is the motor. And then what's significant about this is you're going to have two long lines that you guys are going to have to maintain. Okay? One is the purge system, a purge system line, and the actual other one is the cord for the actual Impella. Okay? Now the purge solution, that big long IV tubing, what that does is it provides fluid out of outflow, and it protects our motor. Because remember, we're unloading 4.3 liters of flow through this cannula, pushing up against that motor. So on your screens, you're going to see a purge system, a purge solution. It's going to have a pressure, and that's something that the ICU nurses kind of take a chart of when you guys actually get there, okay? Let's get back to the business end of it. So this is what you guys are actually going to see in the back, okay? So this is going to be sitting at the actual arteriotomy, at the actual site. There's two different locks here, and then we'll point them out on the slideshow, but there's two different locks. One connects your repositioning sheath, your sterile sleeve, almost like a swan catheter, all that kind of stuff for my hospital folks, to your actual sheath. Okay? And then the next one is the most important one. It's this lock right here. Okay? So you have a T-lock, and then you have a TUI lock, almost like a swan catheter lock. Okay? This pump will move like a jet ski if you allow it to. Okay, so if this lock is unlocked, this pump will move. Okay, this is something that you guys will take a look at, or if you want your nurses to point out to you, just to make sure that this lock is tightened down on transports from your gurney to the bed, from their bed to your gurney. Right, this is what's going to have your pump move on you. This second lock here. Okay. Red connector cable, purge solution, all the way back to your white connector cord. When you guys get from one hospital to the next, they actually take this pump out of their console, or when you're transporting, and plug it into their own console. Okay, and this is what records all of our information. Okay, so we're able to transfer from console to console. You want to pass it around and take a look at it? All right, so let's get to the slideshow. So some of the objectives we're going to talk about is preparing to transport, some of the things that can go wrong while you guys are in transport, and some of the things to look for when you actually present it with a patient and taking them up to the transfer from hospital to hospital. Okay? All right, so like I told you guys, we have a couple different size pumps. 2.5 and CP are the main ones that you guys are going to be transporting. We also have surgical devices, our 5.0 and our 5.5. 5.0 does 5.5 liters of flow. And then our 5.5 is our most surgical device. It's a direct aortic or only axillary cut down, and it does 6.3 liters of flow. Almost like a LVAD, right? So your 2.5s and your CPs are going to be femoral or axillary, like I stated. And then I'll show you guys or talk to you guys about what you guys are going to be actually looking for once you actually pick up the patient. We also have an RP device. I don't see you guys seeing these too much. There's only one hospital out here that has it, and it's Boone. So if you're flying from Boone to another facility, you might see this device. But it is a right-sided device. It provides 4 liters of flow. It sits in the IDC all the way to the PA. So it's bypassing your RA and RV, okay? So it's providing support for the right side compared to the left side, your systemic support. This is what we do, okay? So we decrease your end diastolic volumes and pressures while increasing your aortic pressure and your flow. When you put these devices in a cath lab, most of them are on some type of inotropic pressor, right? So they're on some type of contractility or vasoconstrictant, right? So what we try to do is, once we actually place this pump, we want to start to wean those drips, okay? We want to start to wean those drips off in the cath lab, because if you're on one inotropic pressor, one high-dose inotropic pressor, do you guys know your in-hospital mortality rates? I've never heard of it in the hospital mortality rate contributed to that medication. So 1 is about 22%, 2 is 44, at 3 you're about 80% in the hospital mortality. Okay, so as we add those on, we're increasing the risk of fatalities, right? So once we put this device in, we want to actually start to decrease it. So we see that our systemic pressure start to go up, and we are maintaining a more constant diastolic flow. This is the RP. It's designed a little bit differently. It's a lot stiffer cannula, a lot larger. I'm not going to talk too much about that one. I went over some of the things that are actually on our devices. They're all kind of standard with transitioning from the pigtail to the cannula back to the red connector cable. It's just they differentiate in size, okay? Our CP, the one I'm passing around, is 14 French. So compared to the balloon pump, right? Balloon pump is 7 French sheets, we're a 14 French sheet, okay? So it's a lot larger hole, and there's a couple things that come along with that. Optical sensor is what we are trying to teach more people. So what you're going to see on our screens, there's going to be an LV tracing or an LV waveform, okay? It's going to say LV EDP. It's not actually giving you that LV EDP from the pigtail, right? In the cath lab, we stick a pigtail down in there, we flush it, we zero it, and we get that LV EDP. This optical sensor is going to give you that LV EDP. It's a calculation between the sensor and our motor current. It's not an actual LV EDP, but it's going to be very, very close. We use that LV EDP to determine one of our biggest things that happen with us is suction, okay? Suction comes 2 ways, continuous or diastolic, okay? Continuous or diastolic. Continuous means when we place this pump, it's going up underneath some type of papillary muscle, sucked up against the wall, right? We've moved it somehow, right? And it's somewhere it doesn't need to be. Diastolic or intermittent means a volume-related issue, right? Cardiogenic shock, they're spiraling down a circle, systolic is below 90. They don't have enough reserve, right? They don't have enough volume in them. So we kind of resolve those with volume. So I'll show you guys how we can help and use that LV waveform to determine what type of suction you're getting while you're in the flight. And how do we correct those actions, okay? D5W, D5W, D5W. It's the thing that we need to see hanging from our purge solution, okay? D5W is what helps protect our motor and elongate the longevity of our motor, okay? So D5W, and normally they add some type of heparin to it. We recommend 25 units per mil, okay, of heparin be added to our purge solution when they're coming from the ICU or the cath lab. Some cath labs don't add it. Don't worry about it if you don't see it. They can. They're so anticoagulated in the cath lab if they're doing a hot transfer. They're so anticoagulated above 400, we're okay. We can leave heparin out for about 3 hours. Okay, so if you guys see a D5W bag hanging with no heparin, just say how long has it been since they've had some type of heparin or anticoagulation. Okay. All right. Man. Purge cassettes, purge disc, okay? This is what that long tubing that's gonna be coming out of your actual console. If I open this up, this is where the purge cassette and disc are housed, okay? You guys really don't have to do too much with this unless you guys see a purge alarm, okay? If you see a purge alarm, just notify whoever's in flight. If you guys wanna take my number down, I'll give it to you guys at the end. call me at any time you guys get an Impella. I don't care what time of day it is, what time of night it is. If you guys have an Impella, just give me a call. Okay, I'll know that the transfer is happening, and I can either meet you guys there or come to the hospital that you guys are at. Okay. The purge cassette, purge disc, they put those in the cath lab. It's just maintaining the wire from the patient is what's going to be the difficult for you. The reason why I mention this, Barnes downtown in St. Louis, they're known for what's called the Impella. Okay? So what happened was, the patient, this got lost up underneath the patient because it wasn't connected, right? So it got separated from this cord, and there were some cracks in this one. So some fecal matter got into them, right? So we want to maintain, we were able to save it, pull the pump out, but we want to maintain the access of where we know this device is, because this is going straight down into your aortic root, right? So if you don't see a clamp, just clamp it right there and just maintain, when you're doing patient transfers and movements, maintain wire access at all times, okay? Any questions so far? No? AIC console is pretty straightforward, okay? In trying to diagnose issues or errors or what's going on with your actual device, your Impella is going to tell you what's going on, okay? Trying to get this thing to start. Let's see if it does. So, with your AIC console, you're going to have 5 soft keys on the right-hand side. From what you guys are looking at on the left-hand side of the screen, okay? You're going to have a mute, a flow control, display, purge menu, and a menu button. Your biggest buttons are going to be flow control, okay? Flow control determines what the performance level is on, or how much this pump is flowing, okay? So, in mid-flight, you guys are going to see different types of alarms, possibly, hopefully not, okay? So a red alarm, okay? A red alarm is a very critical, time-sensitive alarm, okay? That means the pump is in the wrong place. Now, this new catheter that you guys have, or that most of the hospitals have, will tell you where it's gone. It will say Impella in ventricle or Impella in aorta, okay? The thing I want you guys to remember, a red alarm means turn down the P2, okay? That means going into that flow control, if this thing ever starts, turning it down to P2 and pressing this button in, okay? So you actually have to press the button in to select the actual performance level. So red alarm means turn down the P2. A yellow alarm is your suction events, right? So the yellow alarm is that continuous or diastolic suction. We got to determine that. We'll make a correction here in a second. But the first thing you want to do is turn that performance level down by 1 or 2 P levels. So if we're sitting on P9, we always want to go down to P8 or P7. All we're trying to do is break that suction first, right? So we want to break the suction first and then assess hemodynamically what's going on with the patient, or has this pump moved, right? Is it a continuous suction or a diastolic suction? For your very sick cardiogenic shock patients, you might see that alarm, Impella position unknown, okay? What that means is your systolic and diastolic pressures on your Impella pump are within 20 millimeters of mercury. Like, they're really close, right? So we're providing most of the support for the heart with our flows, right? As long as we have a good map. Our map is what we want, is 60 to 80. 60 to 80 map, which is a good map for us. We're resting the heart, the brain is getting perfused with oxygen, right? And organs are being perfused. So this Impella position unknown alarm, you might see if you have one of those really, really sick patients. They're on a lot of trope suppressors and all that kind of stuff. We look at map, we look at flows just to make sure that they're good. So these are those 5 alarms I was talking about. The second one is that flow control. I'm gonna switch these pumps out in a second. See if we can get it to work. So flow control, to make the changes, you actually press on flow control. You'll turn this rotary dial down, and then you have to push it in to select it, okay? Really, really simple. With this device, you do not want to go if you're breaking that suction, right, you're turning it down about 1 or 2 P levels. You give it a minute, see what's going on with them, see if it'll break that suction. If you get all the way down to P2, stay at P2. Okay, so P2 is the lowest flow that you want to be on while across the actual valve. It's a big straw, it's a 14 French straw, right? So if we turn it down below P2, we might have retrograde flow, massive AI, right? So we don't want to cause that. So P2 is what we want to stay on while we're across the valve, okay? Or while we're in flight or while we're trying to break that suction.
So if it doesn't ever break the suction, you just stay at P2?
Stay at P2, give a little bit of volume, give a little bit of fluids, and that should help out a little bit. You should start to see your pressure going up. Because we're moving 4.3 liters. If you give them volume, we can move that volume. We're gonna assess why we're losing, right? Are they, I don't know, do you guys transfer any like ECMO patients or anything like that? No. Okay. So are they bleeding somewhere? That's gonna be the biggest thing. Are they bleeding from somewhere? The site, some type of tubing, right? So we look for bleeding if there what kind of volume we're losing, but volume is gonna probably be your number one if it is a suction, okay?
Now, does this cause a little bit of aortic insufficiency just because it does go through those valves?
It does go through the valve, so your heart's still gonna try to compete a little bit. So as of AI, with the forward flow, not too much AI, but we are, I mean, it's a straw, so very, very minimal. We cause very, very little damage to the actual leaflets, right? The only time we will actually cause damage if it's a really aortic stenosis and they have some heavily calcified, and we're not supposed to be placing that because it's a counterindication and we try to punch through that, right? So that can cause some little bit of trauma, but with us moving that amount of volume, right, you're not gonna have too much retrograde flow coming back on it, okay? Now, if you have a high afterload, right? If you have a high afterload, high dose antidepressor, all that kind of stuff, increased vasoconstriction. Now, we are preload dependent, afterload sensitive. So if you have the high afterload, right, and the valve's not opening, right? So you might see slower flows on your device. If you're turning it down to P2, you might get some retrograde flow then also, right? Trying to break that suction in that case. In the bottom left-hand corner of your Impella, you will see your flows, okay? Let me switch this up real quick. Sorry, guys. So we can actually get it going and running so you guys can actually see what it's doing. Any questions so far?
I had a position alarm once and it was directing me towards the yellow connector valve on the thing. It was directing me like what to do,
Yeah.
steps to read, to troubleshoot it.
Uh-huh.
And I was unable to disconnect it. And I don't know who put it on before me, it was just like super strong and I just was unable to with both hands, but.
Yeah, so if you have that event, don't use Kelly clamps on it because.
Yeah, I didn't, my partner was like, can't any Kelly clamps? And I'm like, I'm not gonna do that.
Yeah, I've seen them a lot when people try to use Kelly clamps or some type of scissors or something on it and break that. We can do a little troubleshooting at that point in time, but if it's directing you to disconnect here, if you have a loose connection here.
Okay. So I mean, I don't recall the exact verbiage that it was directing me. Do you know? I mean, do you remember what it would?
That would probably be like a purge solution low alarm, purge flow purge low alarm.
And that was for position alarm.
So if it's a positional alarm, it's gonna be a red alarm.
Yeah.
So it's a red alarm. So if it's a red alarm, it'll say turn down to P2, right? And then assess, for any red alarm, it's gonna say assess positioning for the device. It's not gonna have you disconnect here. So I'm not sure. Yeah, it's not gonna have you disconnect yellow to yellow unless you have what's called like a D-air purge. If it's like, if me and the cath lab tech laid the D5W on the patient's chest and transferred them over to you guys, right? And then there's air in the line, it's gonna have you disconnect at that yellow portion. If you're leaking and the person like me didn't connect it or reseated it wrong, you'll get some errors. But you shouldn't have to, like a position related alarm, you shouldn't have to correct that at all.
Hey, Jennifer, can you pass me?
Any other questions? So this pump, instead of you trying to have to figure out what's going on with this actual patient, it will actually walk you through step by step.
So I have a question, so let's say you get him from straight from cath lab, and do you have to switch it over to standard configuration, or can you let that be for a little bit?
You do not you no longer have to switch to standard configuration at all.
Okay.
So with this pump, it's actually connected all in one. And you remember, you used to have this little red sidearm that's no longer there anymore. So you don't have to do the normal saline, you don't have to do the pressure band and all that kind of stuff. So it's automatically in what's called standard configuration. We're gonna automatically ramp up to auto and give you the maximum amount of flow. So like when you're in flights, you don't have to worry about in 2 hours, is this pump gonna scream at me? Because it wants to go into transfer standard configuration.
Okay.
Let's see if this one will work. Alright, let's move on. So on these devices, you're always going to have on every left side device an aortic waveform. Okay, it's coming from that optical sensor. It's sensing what's going on directly at the aortic root. You're going to have a motor current, your flow control, and then that first information I was talking about. We're not going to use our aortic tracing or our aortic waveform as a diagnostic tool. If you have an art line, use that. Blood pressure cuff or your invasive monitorings, you're going to use those first. If your blood pressure cuff's not working, you don't have an art line, you can kind of see what's going on with it, but we can't level this, we can't flush it, we can't do anything like that like an art line, right? So we don't want to use this as your diagnostic tool to titrate drips or anything. But it is going to be very close to what you're seeing on your art line, okay? You can always tell what kind of device you have in the upper left-hand corner. It will tell you Impella CP, Impella 2.5, Impella 5.0, whatever device. We use this same console for all our devices. We use this console for all the same devices. So all right, so device will automatically tell you what's going on, your flows, and your motor current. So big thing about this device is, we always say 2 pumps, happy pump. You want a pulsatile waveform or your placement signal, and you want a pulsatile motor current. Big thing about your motor current tells you the difference in pressure between the aortic valve, between your aorta and your LV. If your motor current, your green line goes flat, your pump is in the same chamber, okay? And your Impella should be alarmed, okay? Or getting close to alarm. So that pulsatile motor current, that green waveform that you can barely see, if it starts to dampen on you, you know your pump is moving, okay? This is going to be your RP waveform. It's going to be very similar to PA pressures. It's a little bit different than what you would normally see on your actual, the left-sided devices. And as you can see, it's a lower flow state system. So our waveforms are going to be dampened just a little bit because we're providing the pulsatility. We're providing a little bit more pulsatility. So every couple beats, you'll actually hear the Impella or see the pulsatile marks on the actual Impella. Thanks for that. Let's see if we can get this one to start. So these are those alarms. These are what those alarms will look like right across the top of your Impella catheter, okay? So if it's moved too far into the ventricle, you'll get a ventricularized waveform. Too far in the aorta, you'll get the aortic tracing signal, but you'll also see some LV pressures normally, and they will go away, and it'll say Impella in aorta. Impella position wrong is no longer one of our errors. and you'll hear this annoying beep. Alright, so these are the steps for that suction alarm like I was talking about. You have a low volume state in the left ventricle, your incorrect pump positioning will give you a suction alarm, or you're in right heart failure. Do you guys know, just for knowledge, do you guys know how to determine if your patient is in right heart failure? Or like a quick calculation that you can do? Alright, so if you have a Swan catheter in, okay, if you have one in, or they hook one up to them, if you do PA systolic minus PA diastolic and divide it by your CVP, anything less than 1 is severe right heart failure. So you might get some suction, okay? So that's something, if they're in the cath lab and they put a Swan in, they hook them up to the monitors and you see those pressures, you can do a quick calculation. PA systolic, PA diastolic divided by CVP, anything less than 1, they're in right heart failure, or there's some type of right heart failure, right? So you might get suction on the trip. All right, any questions while I try to look this one up? No? Okay, this seems like it's gonna work. All right, so as that ramps up, we'll talk a little bit about this. CVP, normal CVP is what, 0 to 8, right? Something like that, right around that time. We want actually 12, right? So we want a little bit higher CVP because we want that preload. We want that actual preload to get over to the left side. If it's that 10, 8, 9, that area, that doesn't matter. We're okay with it as long as you're not getting any type of suction alarms, okay? Okay. And again, with yellow alarms, with any type of suction, you want to drop it down by 1 or 2 P levels to break that suction and then assess hemodynamically what's going on with your patient. This is probably one of the alarms that you saw. The purge pressure high you were talking about directed you towards that. And this is what assess the yellow purge system. So you want to look at the yellow purge system to see if it's something's going on with it, right? But it won't ask you to disconnect. Just assess it, just tighten it down if you can. Purge pressure low, that's when you're looser, when you have a loose connection. Air and purge. If we get air and purge, anything that happens with your purge system, go up underneath purge menu. Pretty straightforward, right? Anything that happens in the purge system, go up underneath purge menu. If you go up underneath purge menu, and you're walking through this air and line procedure, it's gonna walk you through step by step on how to de-air your purge system, okay? So if I hit de-air purge system, it will literally walk me through each step, and it will not start the next step until I've completed the last, okay? So, if we hit next, this is when it's talking about disconnecting your yellow to yellow. And it will start to purge for you, okay? And if I try to connect this and say, oh yeah, the air is out, it will stop me. Right? So it'll say disconnect the yellow lower and we'll continue the process, right? So you cannot move on until the actual console is ready for you to move on. Even on a red alarm, it's gonna say assess positioning, right? It's gonna tell you to turn down the P2, assess positioning. You guys can assess positioning, right? So just turn it down to P2 and let it ride. If we sit in P9, P8, what can we call if we're in the wrong position?
Suctioning.
Suctioning, one. What else?
Can it damage the inside of the?
Inside the LV, right? Or we can also cause hemolysis, right? We can start to shear some red blood cells, start causing some little bit of kidney damage, right? So we always want to turn it down to the lowest setting if we're in a different position, because we don't want to cause that trauma. If it's too far in the aorta and it's sitting right at the aortic valve, we're causing turbulence at the aortic valve and starting to shear those red blood cells. So we can even damage the leaflets if we're sitting in that position, okay? General patient care considerations, Impella position unknown, this is that alarm I was talking about, right? You're within 20 millimeters of mercury, but you're mapping okay, okay? Your motor current is pulsatile, meaning you're on the opposite sides of that valve, right? Your flows are still good, right? So we have 3.5 liters of flow in systole and 3.1 liters of flow in diastole, right? So our flows are still good for the position that we're in, okay? So if you ever get this Impella position unknown, look at your map, make sure you're within that good mapping range, 60 to 80. Your motor current is pulsatile and your flows. Look at your arc line, right? Make sure your arc line is good also, right? You wanna look at those first and then look at our pressures, right? Our diastole, again, our goal is above 60.
Are these troubleshooting steps on the monitor?
The troubleshooting steps, yes. So if you see Impella in position in the aorta, it will read just like the previous one set. Let's go back to it. You can't really see this, but the top line says Impella ventricle. So it's reduced down to P2 and assessed with imaging. The physicians can actually reposition an Impella ventricle bedside without echo. Echo is our best way that we monitor and look at these devices, but it will walk them through the guide of how to pull this pump back bedside. If it's in the aorta, it's going to tell you reduce down to P2 and then reposition with imaging. Okay, so it's always going to walk you through with the error of what's going on with the actual device. Okay, suction is just going to say turn down about 1 or 2 P levels, assess hemodynamics. All right, so if you're in flight and CPR is required, okay? If CPR is required, hands on chest, and then we can try to turn it down to P2 if we can, okay? Selecting the selector knob, right? So we're gonna go to flow control, selecting the selector knob, rotating it down to P2, and pressing it in, okay? And that'll actually decrease it down to P2. Once you got pulse return, confirm motor current is still pulsatile, right? The green line is still pulsatile, meaning we're across the valve, and then we can slowly start to turn it back up, okay? Slowly start to ramp it back up. On this scenario, you might get a little bit of suction, you might have to give a little bit of volume at the level that you're at, but you wanna return it back to the previous P level and what you was at. So if you picked up at P8, give a little bit of volume, turn it up to P4, P5, let them sit for a second, up to P8, just to make sure we don't get any suction, right? If we have to shock a patient, shock them. Don't worry about the pump. Don't do anything with it. Just shock them. Once we get them back to that regular rhythm, assess motor current, right? Or looking at that green line just to make sure it's pulsatile. We're across the valve, and then we're good to go. Okay? But yeah, no changes needed to be in the AIC. If we have to do CPR after defibrillation, drop it down to P2. CPR P2, red alarm P2, right? Big considerations when you're getting these patients, maintaining the bed no longer than 30 degrees, no greater than 30 degrees. We don't want them to be doing a sit-up when the device is in their groin. It's a 14 French sheath, right? So as we sit them up, we elongate the arteriotomy and cause oozing. Assess insertion site for bleeding, not only the anterior portion of your patients, laterally also. Some of these physicians like to stick through and through. unfortunately, right? Causing some type of bleed on the anterior or posterior side. So check laterally also. Ensure the white pump, there's no kinking in them. Just do your normal IV tubing checks, right? Making sure your lines are nice and straight. You maintain them at all times. AIC plugged in. This AIC console can last an hour. Okay, it can last an hour without being plugged in. So as soon as you get into transport, go ahead and plug it in if you can. Most of the times, what I like to see or what people do is take this little console off, plug it in the little seat belt right next to them, okay? This console does come off of this stand, okay? So there's two little connections back here in the back, the little twist knobs. So we just twist on the back and we're able to just lift this pump right up, okay? ACT, do you guys take ACTs?
No.
PTTs or anything? No? Okay, don't worry about that. But when they get to the Cat 5 ACTs, what we like to maintain them as at 161. You got it?
No,
Okay.
I don't know what's taking it down there, but
It's just a long cord.
I just don't want you to water it.
Yeah, I don't want that to go anywhere. All right? All right. Alright, so preparing it from transport, there's a couple different things. Make sure the AIC power on is, and the power on is ready to go, right? So this is actually talking about when you're actually getting to the new facility. If you're in contact with them, just make sure that they have the new AIC powered on, because it does take about 1 to 2 minutes once you get there for this console to come up. When you're doing an AIC to AIC console switch, we like to be there because there's some steps in there. If we don't do them, right here, this yellow lure, we can cause a little bit of issues or suction with them. So if you didn't see my face at one side, hopefully you see my face at the next side to do the AIC to AIC console. But all it is basically taking each device out. So this will pop right out, and this slides right out, okay? And putting them into a new console. Okay, so we're just transferring from AIC to AIC, and that's how we're transferring all this information. So you don't need any more tubing, you don't need any of that kind of stuff. All we're doing is taking it out from one console and plugging it to the next. Once it's the catheter is connected, it's just going to prompt you to say okay. You're just going to hit the okay button or press the rotary dial button in, and then it should automatically start to ramp back up. But the nurses do that once they come to university or they go to Boone or all that kind of stuff. They're pretty well trained on that, and they can walk us through that. Okay. Those are those two little knobs in the back I was talking about. We just turn them vertically to allow the actual AIC console to be popped up. We put a lot of words on these slides for us to read through, and it's just pretty straightforward, okay? Put a lot of words on it. But let me show you some of the alarms. Oh, I don't have the slides. That's a number that you guys can call if you guys are in transport and having issues, or you guys can call me. My phone number, if you guys want to take it down. Or you're about to get one and you're flying, you're like, hey man, I don't remember a lot of this stuff. What's going on, right? 314 337 1720. Again, that's 314-337-1720. You guys can call me at any time. Anytime. I have 3 other teammates that were always in the area somewhere, and we'll be able to come up and help at any point in time. Or if you guys are mid-flight, I have people call me mid-flight and say, hey, my pump is alarming. This is what I'm seeing. They FaceTime me, right? This is what I'm seeing on the console, and we're able to handle it. Okay.
If we call that 800 number, do we get somebody on call or?
You'll get someone that's in a CSC in Danvers, Massachusetts that actually trained me, right? So they know all the ins and outs of this pump. But they're on 24/7. So if I don't answer the first ring, they will answer. It's in the middle of the night, right? And then they will get me on the way.
I think I have you saved under Impella guy for from a while back.
From a while back, yeah. Were you the one that called me?
Yeah, well, wait, I think you were looking at it remotely.
Yeah. So if you're going from the university, they have what's called Impella Connect. So what happens is, as soon as someone connects a pump at the university, soon to be Boone, hopefully a Lake Regional here soon also. What happens is they actually send me an email saying a pump has been connected at the university. And I can actually see your consoles remotely. So if you get an alarm, a suction alarm, a position related alarm, I'll actually get an email and say there's a critical alarm going on with this pump. And I can always call you and say, hey, you know, what's going on? What can we do? Is he bleeding? Is he looking at that, right? So what's going on with this actual patient? But yeah, it's called Impella Connect. That's for the university for transferring a patient from there. All right, some things I want to talk to you guys about really quickly. And it's on my other slides, but I don't have them. When you guys get patients, okay, they're taught in the cath lab that this blue suture hub is right at the arteriotomy. This is where most of your oozing and leaking and hematomas are going to come from, okay? So, whether you have a really skinny old lady, right, or a really big linebacker, right, the angle of entry on which these cath lab doctors put this device in really helps, right? So, if you have a skinny little old lady and your arteriotomy is pretty flat, or you have a big linebacker, right, that's going to be a more steeper angle. If you guys try to tamp this device down with tegaderms or applying pressure, you're going to cause more oozing or leaking for yourselves. Okay? So when you assess the patient when you initially get them, take a look at that site. Okay? See if it's a steep angle or a really flat angle. Okay? If it's a steep angle, leave it at that steep angle. Because we went from a 14 French sheet to a 13 French repositioning sheet. So there's some space in there, right? This is designed to just cause a little bit of hemostasis and not fully encapsulate in that arteriotomy. So if it's a small angle, don't put your hand on it, don't press down, don't put anything on top of it, right? If it's a really steep angle and they have some gauze on in there and they're bleeding, not oozing, you guys want to hold pressure, that's fine. But however this catheter naturally lies in that arteriotomy, we want to keep that same angle of entry. Does that make sense? Okay? Because I see, myself included, man, I used to take this thing because I didn't want it to move. I knew if it moved, I was getting yelled at, right? And I used to really tamp these suckers down. But what happens is that arteriotomy inside the hip is elongating, right? We make a smooth little transition, and now we're bleeding and oozing. We don't know how to control that, and we just take our fists and push down on it, or we take our two fingers and really push down on it, right? And all we're doing is causing more trauma to the actual tract. So wherever this catheter naturally lies, if you're having some oozing or bleeding.
So are you saying if there is oozing and bleeding, applying too firm of manual pressure is just not the thing to do?
Not the thing to do. I'm gonna show you the technique I do actually. So the catheter is sitting in the patient's body just like this, right? You have a catheter going down to the arteriotomy. I take two fingers around the side of the catheter, from the catheter, from the arteriotomy side, and press down, because your angle to the actual artery is about 2 finger lengths, 2 to 3 finger lengths for the patient. So I just take 2 fingers right at the arteriotomy and press down around the catheter. Okay? Now you're looking for pulsatility. Is it a pulsatile bleed, or is it looking like a slow track ooze, right? If it's a slow track ooze, 5 to 10 minutes of pressure should really clear that up. If we've caused trauma, it's gonna be a little bit longer, right? So 10 to 15 minutes of that kind of pressure should mitigate what you guys are seeing, okay? Don't just press down on the actual catheter, because you're gonna bend it, you're gonna cause more oozing or bleeding once you try to let your fingers up, okay? So just go around it from the arteriotomy side and really press down, right? To try to decrease that amount of ooze you guys are having. Any other questions? Any questions for me? Big things are, guys, those lines. As you're moving patients, just have a nurse say, hey, you're just designed, you're dedicated for the Impella, right? Can you just take care of the Impella? Because at Boone, we just had a patient have this device pull back, okay? And it went into the aorta and we couldn't get it back across. So, really just have them take a look at those lines during transport. When you pop these babies up, if they want to sit right next to you on the seat or however you want to do it, It has to be plugged in if it's been about an hour, because the device will shut off on you. If this pump stops, we can cause some type of thrombus, since the pigtail is just sitting in the LV, right? And if they're critically in need of this device, right, we don't want that device to stop at all. So,
You said whenever you load, like if we're loading the patient, not to take the D5 solution and put it on their chest, like, so you need to keep it held up the
yeah,
entire
so
time.
when we were loading them in the back of the helicopter, all I did was stand there and held the D5W, because it is a long line. It is a long cord, right? It is a long cord. So just hold it a little bit, right, as you guys are actually loading, and just do a little transfer. For whoever has the bed, whoever has the vent, whoever has that, right? Just do a little quick transfer, don't put them on their chest.
Is that because it's gravity fed or you're worried about air bubble?
I'm worried about air bubble.
Let's say you can't, depurge your line, like, so say it's like, oh, it's got like air, it wants you to depurge the airline, but you can't get to the hula lock, the yellow thing.
Yeah.
What do you do then?
What do you do then? Pray. No, just joking. No, just joking. So your purge solution is gonna go at about a rate of anywhere about 7 to 8 mils per hour, right? So it's gonna be a slow purge through our system, and it's designed to, once it actually gets into our little system here, to stop it. But I don't want to take that risk, right? So what I would say is, if you can't get to the little yellow lure clamp that should be right next to the leg, depending on your flight, assess the critical need, right? So assess your meds, assess your patient, do all that kind of stuff, and then take care of the Impella.
Do you dot on a P2, or do you just?
No, don't doubt on. Just leave it at P2 and let it ride. It should not get past there. It should not get past our pump, right? So it's designed that way. Just don't worry about it. But it will not allow that air bubble to pass through until we actually start that process of de-airing the purge, and then it'll allow it to push it all the way through the system, through that yellow, the little
So you
yellow
just keep
line.
things silent and
Hit mute.
whatever, yeah.
If you can't get to it, you know, but most of the time you should be able to see, if you're loading them into the actual burn or your transport, I would make sure I am able to see this section right here. This is the section you wanna see, right? So if you wanna, most of the time they have this device where it's right on the knee, or right above the knee, or right on the lateral side of the knee. Just uncover their knee for the flight for just a little bit while you can actually see this or assess it, okay? Because if this gets caught up underneath the patient, there's more problems than good.
Do you recommend a knee immobilizer
For all cath labs, put those suckers on, yep. We want them to put the knee immobilizer on, because those little 92-year-old ladies like to kick, right? So if they don't have this lock tightened down, this TUI lock tightened down, your pump will move. Your pump will definitely move, right? So knee immobilizer is best if you guys have them, or if you want to have them place it on the actual patient before they actually go for transport, okay? What other questions are there? Good. You guys
So
ready?
if the lock becomes loose, how do you tighten it?
How do you tighten it? Hold the back of the catheter very firmly, undo your tegaderms, and then tighten it down, right? If you're in transport and you're flying, that might be a little difficult to try to hold a catheter, right? I would say assess it. What you guys are giving off are gonna be reading off the centimeter marking in the back. Okay, there's a centimeter marking at the back of our actual lock, and you just count down. So if it's at 70 right here, 69, 68, 67. You want to keep it at 67 through your flight or your transport. And this is something that you guys are going to be showing the nurses when you guys actually get to the new facility. Okay. What else we got? All alarms, just read them. Just read them. It'll tell you what to do. It'll tell you your steps. Red is what? Turn down to what?
P2.
P2. Yellow is
Suction.
suction. And we try to break that suction. Turn it down by 1 or 2 P levels. And then we'll just assess hemodynamically what's going on with the patient. Take a look at your site and see if they're bleeding or if they're losing from that way. Or they just need a little bit of bolus. Or they just need like a 250 or 500 or whatever. Give them a little bit of volume, and that should break your suction. But this thing is like a jet ski. Where are we on that, P5? So that's what we're doing in the aortic root, right? So we're putting that coronary forward flow through that catheter, right? And as soon as we let this device go, it's gonna take a jump. It's gonna dive down itself. All right, guys, this is a good margarita mixer. Real good margarita mixer. All right, any other questions for me?
Please tell me at conferences you actually have margaritas and sit there and mix those with those.